Invite Dr. TEJAS, everybody knows him. He's talking about the abnormal corneas, how to manage the post-refractive surgery, post-RK patients, post-keratoplasty, and the particularly focus on the how to measure the calculate the IOL power calculation in the keratoconus patients. Over to you, Dr. TEJAS.
Okay, sorry for that. A very good morning. And like Soumil said, meeting all of you after a long time. And I thank Twinkle for keeping me as a lucky charm in all his courses. And we have been doing this course for now more than 5 years. 5 plus 2, that is 7. IOL power calculations in abnormal cornea. Well, so everything here is not normal. And it will be a tall or a very optimistic goal that we end up with a emmetropia. But let's try to do something where we have at least a functional vision for the patient, and that too without glasses. So I'll just try to at the outset clarify what is an abnormal cornea, especially for IOL power concern, because I believe almost everyone sitting here has bent and bruised the cornea at one part of their life or in 1 week of their practice, at least once or twice or more if you are a refractive surgeon. So the poor cornea is always the first victim, and as we understand our Duke Ehlers type of anatomy, cornea is the first refracting surface, and that is also the most important refracting surface. And so whenever this particular structure of the eye is bent or bruised, which is because of the refractive surgeries or any kind of a trauma, we always end up with a lot of issues. So I'm going to talk about the post-refractive surgery corneas. These are abundant right now, and probably in 5 years' time, every third patient who comes to you for a cataract would already have a corneal refractive surgery done on their cornea. And there we have LASIK and PRK and the RKs. Luckily, the RK patients are now dwindling, and less patients of RK turn up for cataract. But then against that, the LASIK and PRK has exponentially increased. Corneal scar and dystrophy, these are the poor patients, and they always are going to struggle for a good vision. So why not make them happy with less glasses or less of irregular astigmatism? Corneal degeneration, keratoconus, well, somehow, just like we always think that in the present situation, the number of patients with glasses have increased. Well, it is not the number of patients of glasses have increased, it is the awareness which has increased. And similarly, the number of keratoconus patients. Probably a lot of you might have seen a patient who is 45, 50, 55, and when you do a corneal study, you might say, well, he had an keratoconus, but it did not progress, but he still had a keratoconus grade 1 and grade 2. So all these patients are going to be a challenge, and also the post-keratoplasty patients. Luckily, nowadays, there are more of lamellar surgeries rather than total penetrating keratoplasties. So let's first of all talk about the subgroup, the corneal refractive surgery patients, especially the LASIK and the PRK, and trying to do IOL power calculations. So to go back to our basics, the regular cornea, the regular formula, when you use, we were not taking effective lens position into account. In these regular formulas, they consider that cornea and IOL are assumed as a single plane. But it is not so. We all have now understood, thanks to the companies which have made us understood, which have explained to us all this. They also have to go ahead and innovate new machines, and we have to buy them. What actually happens in a conventional keratometry? Again, going back to the basics, it measures the anterior corneal curvature only. It also presumes that there is a fixed ratio between the anterior and posterior corneal curvature. And now, like I said, probably in 5 years' time, every third patient is going to have his or her anterior and posterior corneal curvature changed. The keratometric index of 1.3375 is used to calculate the corneal power, and it does not take into account the corneal thickness. Same way we have started understanding the importance of corneal thickness in glaucoma, here also the corneal thickness has started becoming an important factor. What happens in a post-LASIK patient? Well, you all know, well, this is a bit of an exaggeration. It is not such a top hat in this prolate cornea days, but well, just trying to explain to that this ratio is changed. What are the problems if we use the conventional IR power calculations? Well, like I showed in the previous slide, there is an abnormal Gulstrand ratio. Effective corneal area. Well, this is something very important. Whether you are measuring which part of the cornea or whether you are interpolating the data in the visual axis. And of course, very effectively talked about the wrong effective lens position estimation. So we need to evaluate the true corneal power. Like I said, the cornea, the poor structure is always bent and bruised, and that's why we need to measure the true corneal power. And Harshul very well explained the different types of machines. Because of the time constraints, I'll not go into all those things, but we have to understand that the two main important technology we are having right now is the slit lamp or the Skymflux technology and the OCD technology. The instruments are Pentacam, Galilei, and Cirrus. And I can also mention that here we have now Pentacam XR, which also measures the axial length. So, two main important keratometry readings are, one is the total keratometry, which like I believe Saumil explained, which comes along with the Master 700, and they take into account the enter and posterior curvature both, and or the Hollard equivalent keratometry report. These are the two very important measurements which makes our IOL power calculation more precise. So how to tackle this issue? The post-refractive. Well, like I said, use the measured, that is the total TK which comes with the Master 700, or estimated, applying correction factors which is in the EKR in Pentacam. Like I said, they interpolate the data. They measure, they have no blind spot, which is the advantage over the total K. They have no blind spot, but then they interpolate the rest of the data after measuring the central 3 mm. Use formulas like not relying at all on corneal power. Well, this is something very important. Many times we have patients who would not even know that a refractive surgery was done 20 years back, or would not want to tell you if their spouse is with them. So it could be like the formulas of without corneal power are the Aramberry, the double K, the high gaze, the Pressner, the Olson, and the Oculix. These are the formulas which have started helping us, even if we do not know the corneal power, the pre-surgery corneal power. Again, coming back to the same conventional, use the measured or the estimated true power. Very, very friendly and very important aspect of our IOL power calculation is the online ASCRS post-CRS calculators. This is really something probably in the entire website, this is one thing which we all frequently use and visit probably. Barrett True K formula, which is again online, or it could be incorporated into IOL Master 700. So this is just like, if you don't want to spend money, go online. If you have a lot of money, you can buy IOL Master 700. Holiday 2 is the post-CRS version, where equivalent keratometry in Pentacam HR is used, and the axial length is also used. This is if you are doing your IOL power calculation, though I don't do much, this is a very familiar page that everybody would be aware of and using it. Three main subgroups I would say. These are the formulae where you have everything with you. Your own patient or a patient who's carrying a file 10 years or 15 years before the surgery and having all the data, pre-operative refraction, K readings and everything. Well, you can very well go ahead and use this formulae in this group. This is where we have the keratometry but not the refraction, so some data is missing. And these are the formulae where you have nothing with it. The patient is absolutely new and has no knowledge also, and then you can go ahead and use these formulas. Very important again is the Barrett True K formula, and this is something where the True K IOL power is used, which comes from the IOL Master 700. Let's talk briefly about the formulas which are not relying in keratometry, especially for the corneal refractive surgery cases. The one very important and frequently used is the Olsen formula. Why? Because, and the C constant. What is the importance of C constant? Dr. Twinkle briefly referred to it. The C constant defines the IOL position in terms of the crystalline lens anatomy. So it does not depend on the K reading nor the axial length. So it is bypassing a lot of other data which is there, which is usually supposed to be filled up in the other formulae. Let's talk about, so that was all about the LASIK patients where the corneal thickness was also altered. Let's talk about RK, where remember that the thickness is not at all changed. It is only the entire curvature which is changed, right? I believe everybody understands what I'm trying to tell you, but still it is a challenge. Post RK, well again, like I said, measuring the keratometry is the most important thing. Use several devices to measure the Ks and use the flattest K as average K for calculations. I'll tell you the reason why use the flattest K. And sometimes even measure the keratometry at different time of the day and call the patient for a couple of more visits if that is permissible. Permissible because you might not know whether this K is a stable one or not. Average of 1 mm, 2 mm, 3 mm and 4 mm ring values of topographer always helps. Average central power in AIOC calculator has to be put in, and we should have an access to a modified version of Holiday 1 or Aramberry and the double K methods. This was a very nice paper which actually told us that the accuracy of the IOL power determination can be improved if the flattest calculated K is used in the IOL determination and myopia is targeted as refractive error. So please keep in mind that for post-RK, use the flattest K possible. And like we keep on telling you, always aim for myopic target. And the rule, a certain rule is minus half diopter for 4 cuts RK, which we rarely see, 1 diopter for 8 cut and 1.5 or more for 12 or more RK cuts. Such patients, intraoperative aberrometry is also less accurate, so you're not going to be able to take the help of that. Do non-dominant eye first. Practically, this is not always possible because it also depends on the type of cataract inside the eye, and we have seen that the dominance sometimes changes with the cataract evolution also. And adjust in the other eye accordingly. Of course, we cannot do a simultaneous bilateral cataract surgeries in such patients. Avoid toric and multifocal lenses and use only monofocal IOLs. Again, coming to this paper which says that the OCT formula and the Barrett True K were comparable to the double K Holiday 1 method on the AIOC calculator. However, no formula was able to predict 80% of eyes within 1 diopter of target refraction at more than 4 months post-operatively. Refractive stability when, well, post-surgery, if you have done a cataract surgery on a patient with RK and you want to actually measure the refraction, what is a good time? For 4 weeks, minimum 4 weeks for 4 RK cuts and at least 2 to 3 months for 8 RK cuts. And post that only you will be able to say that this was a post-surgery refraction. Always be prepared for refractive surprise, but it is more important is keep the patient prepared for a refractive surprise, not only you. Okay, so the corneal refractive surgeries group is over. I'll very briefly mention about the keratoconus IOL power calculations. Whenever you have a patient having a keratoconus or a treated keratoconus and a cataract, what are the 3 things that you should be always looking at? The age, the stage, and the stability of the keratoconus. So let's talk about a young patient having about 35 years of age with a stable keratoconus. Of course, you are going to go ahead and do a topography and always use an optical biometry. In fact, I'm not going to go into this discussion of optical versus ultrasound biometry ever in this talk. And the formulas which you would want to prefer are the Haigis L, the Shamas, the Holiday 2, and the Barrett Universal 2. Well, like Dr. Somil mentioned, Barrett Universal 2 is the magic rabbit out of the head. All the results should be in 2 diopters of the Haigis L formula, and this I'm talking about a young patient with a very mild keratoconus and a stable keratoconus. If this is another type variety of patient where the patient is young, the keratoconus is mild, but the stability is not there. What actually are you going to do? Well, you may do a pinhole test, see if the vision improves, then you might think of doing a cross-linking with intrastromal rings and try to shift the cone, or if not improving, well, you can go ahead and do the corneal cross-linking. A middle-aged patient having cataract with stable and mild to moderate keratoconus, again, the fundamentals remain the same. Haigis L, Shamas, Barrett 2, Universal 2, Hills on the ASCRS website, and toric oils to be avoided, which is a universal fundamental for all these patients. Supposing you have a middle-aged patient with advanced but stable keratoconus. Why would you say advanced? Well, the Ks are more than 60, the corneal thickness is less than 400. Well, you might, and the posterior float is more than 40 microns. You might consider doing a triple procedure, DALK, phaco, and IOL. But frankly, after this surgery, it hardly matters whether the patient is -2 or -3 or -4 also, because these patients are struggling to get 618, 612 vision. Similarly, an old patient with 60 years and keratoconus with a mild to moderate but very unstable, well, you can think of doing only a cataract surgery and a secondary IOL post the surgery with aversions formulas. Yes. IOL selection, well, very important is the zero sphericity, which is most preferred. So post-keratoplasty, corneal scarring and degenerations, all corneas, corneal bypass formulas are to be used. And very important is if the other eye is normal, you can try and go ahead and measure the other eye and try to do the IOL power calculation. Thank you very much for your attention.
Thank you, Dr. Tejas sir, for elaborating such a nice how to manage the abnormal cornea. It's a vast topic to cover in such a short